if we look at immunotherapy for multiple myeloma, the start of immunotherapy with really monoclonal antibodies like daratumumab, an anti-CD38 directed monoclonal antibody, and elotuzumab, which is directed against SLAMF7. Now, daratumumab was already active in monotherapy. For elotuzumab, you need an addition of an IMiD, either Revlimid, lenalidomide, or pomalidomide. And in the beginning, those antibodies were really used in patients with more advanced disease. And it could be nicely shown that adding monoclonal antibodies to conventional therapy very much improved response rates and especially progression-free and overall survival. And there were specifically 3 trials that demonstrated the high efficacy of monoclonal antibodies in the treatment of relapsed refractory multiple myeloma patients. The Pollux trial, in which RD was combined with daratumumab, and it could be shown that the addition of daratumumab dramatically improved the response rate, the rate of complete remission, and especially the rate of MRD negativity, and thereby increased significantly progression-free survival. And the same was shown for another trial with daratumumab, the Castor trial, in which the addition of daratumumab to VD increased the rate of overall response, the complete remissions, and especially, again, the rate of MRD negativity, again, leading to a significantly improved progression-free survival and also overall survival. And for the third antibody, elotuzumab, there was a very nice study recently published in the New England Journal of Medicine looking at PomDex for more advanced patients and comparing this to the combination of elotuzumab with PomDex and the 3-drug combination with a monoclonal antibody induced a significantly prolonged progression-free survival in favor of the elo-PomDex combination. So this was the past. Now all these monoclonal antibodies are moving into frontline therapy, and clearly the studies that show the efficacy of the monoclonal antibodies now also in the frontline therapy of multiple myeloma were the Alcyone study, the Maya study, in which the conventional treatment for non-transplant eligible patients, VMP and RD, were combined with the CD38 directed antibody daratumumab. And again, the addition of daratumumab to these conventional therapies dramatically increased response rate, rate of complete remission, and also progression-free survival. And also for the transplant-eligible patients, there are now increasing data showing the high efficacy of a monoclonal antibody already used in frontline therapy. One of these studies is the so-called Cassiopeia study, in which the classical triple-drug regimen for induction and consolidation was combined with daratumumab. And again, it could be nicely shown that the addition of the monoclonal antibody increased response rate, rate of complete remissions, rate of MRD negativity, and also progression-free survival. And in another trial done in the US, the so-called Griffin trial, actually VRD plus daratumumab was again shown to be superior in the response rate, in the rate of complete remissions, in the rate of MRD negativity, and also progression-free survival when compared to the VRD regimen alone. So again, indicating anti-monoclonal antibodies in the induction therapy, in the consolidation, are improving the outcome. And we actually have now data that are showing that even the 2-year progression-free survival is beyond 95%, which is really something we haven't thought about a few years ago, that we could achieve this kind of high efficacy. Now, the next step in immunotherapy is to use a different target and to use different immunotherapeutic strategies. The new target that is now addressed by all these novel immunotherapeutic strategies is BCMA, so no more CD38 or SLAMF7. BCMA, again, is a marker that is highly restricted in its expression to plasma cells, malignant, but also normal plasma cells. It's quite universally expressed on multiple myeloma, and it is actually important for the induction of anti-apoptosis and proliferation. So it's an important marker, and it's obviously thus broadly expressed. It's a marker that has some functional activity and some significance for myeloma proliferation. Therefore, it's a very interesting target to be used in modern immunotherapy. So what are the strategies that we use to target BCMA? One is clearly, and that's the one which is probably coming first in the clinic to be approved, is a so-called ADC, an antibody-drug conjugate. So the monoclonal antibody targeting BCMA is kind of linked to a toxin, and with this, it increases the efficacy of the anti-BCMA antibody. So what do we see in the clinic? Using this agent, which is called belantamab mafodotin. This agent is, first of all, quite safe. So we only see some thrombocytopenia, but there is one peculiar side effect, and these are so-called corneal events. So these patients often complain about blurred vision, dry eye, photophobia, which is a transient phenomenon, so it disappears after some time, but it can be disturbing for some of our patients. So what about the efficacy? So the overall response rate is about 60%, and especially in patients that are not exposed to daratumumab. If they were exposed to daratumumab, the overall response rate goes down below 40%, and the median progression-free survival is about 12 months, again, reduced in patients that were exposed to daratumumab. In this patient cohort, it's only about 6.8 months progression-free survival. So the immunotherapeutic strategies to come in the future are really bispecific antibodies and CAR T cells. Bispecific antibodies are constructs of an antibody which has actually two binding domains. One has a binding domain which is directed against the CD3 molecule on T cells, the other one targeting surface antigen on the myeloma cell, and then there is a small linker which kind of combines or connects these two antibody binding domains. And with this bispecific antibody kind of links a T cell to the tumor cell. And therefore, we form a kind of an immunological synapse, which is independent of MHC class 1 and class 2, independent of co-stimulation. So it can induce anti-tumor reactivity even in a tumor cell like in a myeloma cell, who is often lacking MHC class 1 and class 2 expression, and often lacking also the capability of co-stimulation. And so these bispecific antibodies are redirecting T cells that are maybe specific for a virus, and then these T cells are becoming tumor reactive. And if we infuse bispecific antibodies into a patient, we typically see after some time, a quite dramatic expansion of especially CD8, but also CD4 cells, especially of the effector memory T cell phenotype. And these T cells are then obviously being redirected and mediate the anti-tumor reactivity. Now, as described for the antibody-drug conjugate, the main target of bispecific antibodies used in the treatment of multiple myeloma are actually targeting BCMA. And the proof of concept study was a study, the so-called AMG 420, which was done partially in Germany and partially in France. So it was really a French-German cooperation. And this antibody was dose escalated until the maximum tolerated dose was defined, which was 400 micrograms per day. The antibody is a very small molecule. It's a classical BiTE molecule, so it has a very short half-life. So it has to be given as a continuous infusion. And that's why some of the patients also had some problems because they had central veins or ports. So we had some central vein and port infections. At the same time, this bispecific antibody mediated some polyneuropathy, which we found to be obviously immune-mediated because patients were nicely responding to immunoglobulins and steroids and had a complete resolution of the signs of this polyneuropathy. Some patients had a mild cytokine release syndrome, which was more severe in one or two patients. So that was, again, one of the dose-limiting toxicities of this bispecific antibodies. And what we saw were some opportunistic infections, what we always see in these very advanced myeloma patients, probably also due to the fact that some of these T cells, after this traumatic expansion, were kind of being exhausted. So we actually, so these were the side effects. So what about the effects? Now, at the maximum tolerated dose, 70% of the patients responded, and 50% of them actually achieved an MRD negative CR. And we have now patients that are beyond therapy and still in ongoing complete remission for more than 1 year. So it's a very effective treatment, but we have limited data. And the point is that unfortunately the sponsor of this trial decided, because of this problem of continuous infusion, to stop the development of AMG 420, but to further develop a similar molecule which has a half-life extended, bispecific, the so-called AMG 701, which requires only one infusion per week. So this is ongoing. Another bispecific antibody, which is very attractive, is the CC93268. This targets also BCMA. It has two binding domains targeting BCMA. And also this bispecific antibody was intensively studied in the clinic. And again, what we see, and this has a much more patient-friendly approach. So in the beginning, the bispecific antibody is given once per week. Then after 3 cycles, it's every second week. And then it's after some further applications, one moves to monthly application. And again, this antibody, bispecific antibody, was highly efficacious. So we had 88% overall response rate, about 44% complete remissions. And the toxicity was quite similar to the AMG 420. So there was some form of cytokine release syndrome, some infusion-related reactions, and what was more obvious when compared to the AMG 420, some more hematological toxicity. But again, very well tolerated, also in patients beyond age 70. And there are a lot of other bispecific antibodies targeting BCMA now in the clinic. So Pfizer has one. There's one from Johnson and there is also a bispecific antibody targeting BCMA from Regeneron. Now, with all these T-cell redirection strategies, CAR T-cells and bispecific antibodies, we see the phenomenon that the target molecule is downregulated or even lost. So the strategy clearly is to also, in addition to BCMA, have other targets for these bispecific antibodies or CAR T-cells in case of an antigen reduction or an antigen loss. And one of the very important targets that is also now used for bispecific antibodies and CAR T-cells is the GPRC5D molecule, which is also widely expressed on myeloma cells, and at least preliminary or preclinical data show that this is also a very attractive target for bispecific antibodies and CAR T-cells. And so we're looking forward to really use also these in the clinic. Now, when we look at the mechanisms of resistance, because we have obviously seen patients responding, and then failing the treatment, we've seen patients with primary resistance. So what are the mechanisms of resistance that have to be overcome if we treat patients with bispecific antibodies or CAR T-cells? So one is clearly the antigen loss, and therefore dual targeting, for example, with BCMA and GPRC5D directed bispecific antibodies, or in the CAR T-cell field, combining BCMA, CD38, BCMA, CD19, BCMA, GPRC5D, probably in the future will allow us to get around the problem of antigen loss or antigen reduction. And finally, there's also the issue of the tumor microenvironment. We have data from other studies with bispecific antibodies that the increase of regulatory T cells in the microenvironment is clearly inhibiting the activity of bispecific antibodies, but also CAR T cells. And we're starting using depletion strategies for Tregs. And furthermore, there is another interesting phenomenon, that's the combination of Treg, of bispecific antibodies or CAR T cells with checkpoint blockers, because obviously some of these myeloma cells are upregulating immune checkpoint molecules and thereby kind of hiding from these redirected T cells. So the combination of bispecific antibodies and CAR T cells with immune checkpoint blockers could be a very interesting strategy for the future. And furthermore, these are very nice data coming from the lab of Ken Anderson. He showed that the combination of bispecific antibodies with IMiDs can further increase the efficacy of these bispecific antibodies. And at the last ASH meeting, he showed that probably the addition of IMiDs can also downregulate immune checkpoint blockers and maybe also increase the activity of these redirected T cells.